Hello, my name is Dr. Melissa Caldwell. I'm a clinical psychologist and the Director of Mental Health Services for Advanced Correctional Healthcare. Today, we're going to be talking about excited delirium. In particular, we're going to be discussing the phenomena, its characteristics, and the controversy regarding this issue. This is a very important topic in the fact that when we have individuals coming into our facilities, we need to be able to distinguish the individual that is experiencing mental health issues from someone who might be experiencing a medical issue that can have life-threatening consequences. There's scenarios where we have individuals who come in who are acting in a bizarre or even violent fashion. And assumptions about what might be causing that phenomena, that presentation, can have real-life consequences. Consequences that can involve life loss, tragedy, and liability. The objectives of this talk are the following: that once you complete this learning exercise, you'll be able to provide a definition of excited delirium and its relationship to other variants of delirium. Second, that you'll be able to list the behavioral cues and physical characteristics associated with this syndrome. And then finally, that you'll be able to cite the consequences of failing to identify and respond in a timely manner. Let's start off with a definition for excited delirium. This is a term that is commonly used to explain deaths of individuals in police or correctional custody. In particular, this individual is often being arrested or restrained while showing some combination of agitation, violence or bizarre behavior, insensitivity to pain, elevated body temperature, or increased strength. For now, let's set aside the specific term of excited delirium and discuss delirium in general. Delirium is an acute, reversible, diffuse neuronal dysfunction. What this means is that the brain is affected by something that comes on suddenly and severely, and with appropriate treatment can be reversed. Sudden onset is what characterizes delirium, with hours to days meaning the difference between someone who looks relatively normal to being quite ill. The course often fluctuates over a 24-hour period and is often worse at night. People often compare this to the experiences that they have when they have a cold virus, for example, and they find that the symptoms get exacerbated as nighttime progresses. A distinguishing feature of delirium is a fluctuating level of consciousness, as well as of mental status. What this means is that you can have a patient that will at times seem perfectly lucid, answering questions appropriately and behaving appropriately, and then other times the patient may have frank confusion, problems with their attention, and disorganized thinking, as well as behavioral discontrol. Before we go on to discuss variants of delirium, I first would like to explain to you why I, as a psychologist, am discussing what is basically a medical phenomena. I am not a medical professional. However, I am often called on to assess individuals who are exhibiting behaviors and mental health presentations, which unfortunately at times have root causes in medical issues. The concern is when there's a failure to identify a medical cause to a mental health presentation, that means a delay to care. We'll be discussing that further. For safety for your patient, safety for the inmate, and safety for this facility, one must first rule out medical conditions, then rule out mental health conditions, and then rule out deception, in that order. There are three main variants of delirium. The first variant is hyperactive delirium, also known as agitated type. This is when the subject may become physically aggressive and dangerous to other inmates and staff. Agitation, restlessness, and hallucinations are often present. One specific type of hyperactive delirium is delirium tremens, when you see with individuals who abuse alcohol. The second type of delirium is hypoactive delirium, sometimes known as the quiet type. This is when the detainee will often appear sluggish, withdrawn, and lethargic, often to the point of being stuporous. The inmate is often perceived to be depressed. As such, it has the highest mortality rate of the three types of delirium because it's often overlooked. The third type of delirium is called mixed delirium, sometimes called alternating type. This is a combination of the first two, hyperactive delirium and hypoactive delirium. It is considered the most unpredictable and thus the most challenging of the types in terms of managing behavior. It is important for one to know that there are numerous causes of delirium, highlighting the importance of medical expertise in assessing and determining the cause. Such causes include systemic diseases such as liver failure, metabolic factors such as electrolyte abnormalities, and toxicity. Highlighting just how complex this issue is the following slide in the mnemonic I watch death, standing for infections, withdrawal, acute metabolic, toxins, CNS pathology, hypoxia, deficiencies, endocrine, acute vascular, trauma, and heavy metals. The point is, again, that medical expertise is needed to make the determination of cause. Although we do not encourage non-medical professionals to be assessing and diagnosing for this condition, there is a screening tool that is useful in determining the presence of delirium. In this case, a person is considered to have a positive screen for delirium if they have the features 1 and 2 plus either 3 or 4. Specifically, they have the presence of an acute onset and fluctuating course, and inattention, and either disorganized thinking or altered level of consciousness. The recommendation is that although there is screening measures for this, screening should be at the level of training and best left to medical professionals. So let's discuss some of the features of excited delirium. First are some of the psychological features. Discussed in the literature are the following: intense paranoia, extreme agitation, rapid emotional changes, disorientation about one's place, time, or purpose, even disorientation about oneself, hallucinations, delusions, scattered idea about things, easily distracted, a psychotic appearance, and a description of one having just snapped. Verbal features include screaming for no apparent reason or no provocation, a pressured, loud, or incoherent speech, grunting, talking to imaginary people, or irrational speech. Physical behaviors include violence, bizarre behavior, aggression towards inanimate objects such as glass, running for no apparent reason, being naked or partially disrobed, apparent superhuman strength, seemingly unlimited endurance, resisting violently during capture, control, and restraint, continuing to resist violently even after being restrained, diminished sense or response to pain, and self-induced injuries. Individuals with excited delirium have often been described physically as having dilated pupils, profuse sweating, a high core body temperature, skin discoloration, a large belly, foaming, drooling at the mouth, uncontrollable shaking, or respiratory distress. The controversy lies in the fact that the term excited delirium is not recognized by the American Medical Association or the American Psychological Association as a medical or psychiatric diagnosis. It is, however, recognized by the National Association of Medical Examiners. Contributing to this issue is the fact that the term excited delirium is descriptive rather than diagnostic. That is, it does not tell you what the root cause of the presentation, but rather it describes an agitated, confused state. Opponents of the validity of excited delirium have argued that excited delirium is only listed as a cause of death in situations where police or correctional staff are involved in restraining or tasering agitated individuals. Some have even suggested that it is a term to absolve law enforcement in cases of excessive force. Those that believe in the utility and validity of excited delirium have said that although excited delirium as a diagnosis has not been widely accepted, there are existing diagnostic codes that many have deemed synonymous. The following is a list of just some of the sample diagnoses. Proponents have also pointed to historical support, stating that excited delirium is not a new concept or a new label. Excited delirium was first described in British medical literature as early as 1650. Dr. Luther Bell presented the concept in the US in 1849, calling it Bell's mania. In the 1980s, the term was repopularized by Drs. Wheatley and Fishbane, Florida medical examiners, when it was used to refer to a delirium induced by cocaine abuse. The term was expanded to be largely synonymous with hyperactive delirium, a state with numerous underlying causes. Research has provided mixed evidence for the roles of restraint, and as well as the roles for excited delirium in causing death. In particular, there seems to be support for both as having a contributing factor. A review of 21 cases in a study that was published in 1998 showed that of unexpected deaths in people in a state of excited delirium, 18 of which were people in police custody, all suddenly lapsed into tranquility shortly after being restrained, quote unquote. In all 21 cases, the victims had been restrained either face down or through pressure applied to their necks. In 12 of the cases, excited delirium was brought on by a psychiatric disorder. In 8 cases, cocaine was the culprit. In an additional 8 cases, the victims suffered chest compression from the weight of 1 to 5 people. This suggests that restraint does have a role in exacerbating the condition for excited delirium. So taking a note from classical literature, I'll let Shakespeare chime in. Would a rose by any other name smell so sweet? The answer is, what matters is what something is, not what it is called. So there are answers that we can find amidst the debate. First of all, it's a very complex issue. When someone dies, apparently suffering delirium, determining the cause is problematic. Was it the delirium, the taser, restraint, a complex interplay of all the above? There's varied opinions, but what appears to be undisputed is that one must take care with such uses of force, as there is always a risk, and potentially more so for an individual who's physically or mentally compromised. Delirium can increase risks associated with physical restraints. So why is this an important issue? Excited delirium, as with other forms of delirium, refers to a medical emergency with potentially life-threatening consequences. Thus, the importance of having medical providers available, on-site medical or emergency medical services, to assess for its presence and to provide immediate medical intervention. In the event of a death, staff may be held legally liable. So now let's spend a little bit of time discussing the consequences of misdiagnosis. When you misdiagnose an individual, for example, by assuming that they have a mental health condition rather than a medical condition, or if you assume that they're malingering rather than having a medical condition. The first thing that is a consequence is inappropriate or lack of treatment. I was once referred an individual for potential schizophrenia. However, the individual's symptoms more closely match a medical condition, a delirium. When he was assessed by medical personnel, he was found to be experiencing problems with his liver and had a diagnosis of hepatic encephalopathy. In another case, we had a young woman who was admitted to the jail, and she had signs of intoxication, stumbling, slurring of words. However, she didn't have other signs that would generally be present if someone had used alcohol, for example, such as a smell on her breath or a breathalyzer result. What happened is she had taken antifreeze prior to coming into the jail in a suicide attempt and had caused significant impairment to her kidney and other organ function. If the jail had assumed that she was intoxicated, let her sleep it off, she could very well have died in the night. Similar reactions have been seen with individuals with diabetes when their blood sugars are low or blood sugars are high. These are all various causes of delirium. What happens when you misdiagnose an individual, when you assume that they have a mental health presentation or they're malingering when they have a medical condition, is you miss the treatment window and you have increased risk of mortality in a short time period. So here lies the dilemma. You may have a subject who's experiencing a medical emergency that could readily be helped by appropriate medical intervention. If you stand by out of fear of using restraint, hoping the person may calm down, you may unnecessarily doom him. In any case, restraining people who are dangerously beyond self-control, whatever the cause, is a task for those in law enforcement and corrections. However, the trick is to not make a situation that's already desperate and foreboding even worse. So here are some of the next steps in approaching a potential excited delirium case. In assessing, managing an agitated detainee, first off, take precautions to ensure your safety, adequate security backup, and if possible, non-contact observation. Notify a jail physician or EMS as soon as possible. Consider delirium a medical emergency that may require transfer to an emergency department. Transition your approach to the situation from a simple law enforcement or correctional intervention to a coordinated response to a medical emergency. The goal is to get the subject into the hands of a medical personnel or into a hospital as quickly as possible. When making their approach, the first responding officers should focus on containing the individual in an environment that offers maximum possible safety and protects others as well. Unless there's an immediate public safety threat, officers should not approach the individual until substantial backup and medical personnel are on the scene. The subject may need to be taken to the ground. There are benefits of using the ground as a stable, consistent surface for restraining the individual. In terms of control strategies, initially the subject may need to be prone on the ground for handcuffing, but as soon as possible, roll him onto his side to give him the best possible breathing capability. Without hog-tying the individual, control his legs. A hobble restraint strap around the ankles that you can step on after it's cinched is often recommended. For transport, the ankle restraint strap should be tied to the end of the ambulance gurney. This protects EMS personnel from thrashing of legs and keeps the subject from pulling his legs free of the stretcher that is usually placed across the knees. Here are some things to avoid. As individuals with excited delirium have been known to be impervious to pain, avoid using control strategies where pain is the mechanism. This includes tasering the subject in the stun mode, use of OC or baton. If the individual can't feel it, he won't be controlled by it. You'll only end up connecting the use of force to his death if the individual dies, without winning any benefit in the moment. Likewise, multiple taser strikes are not recommended. Next, try not to cause any impairment to the subject taking full breaths. This can include spit masks or towels over the face. Again, your safety comes first, but if possible, avoid these, as it lessens fresh air coming in and retains exhaled air. Also avoid the use of neck restraint, as it may lead to the perception by the individual or the observing public that you are cutting off the individual's breathing or circulation. If the individual thinks he can't breathe, this may increase panic. Finally, avoid transporting the subject in a police car unless no other option is available. An excited delirium subject is not likely to sit quietly on the seat for you. Laying him on his belly is not recommended because it may increase respiratory distress, and laying him on his side will often result in windows being kicked out. Transport to a hospital via ambulance whenever reasonably possible is recommended. The purpose of this talk is to prevent deaths from excited delirium. However, when someone is medically compromised, the risk of death is quite real. As such, we have to be conscious of the issues related to risk management. If the subject does die, ask medical personnel to take core body temperatures at regular intervals even after death. Presence of an elevated temperature may assist the medical examiner in establishing a firm cause of death. Be thorough and timely in documenting your observations and responses, for example, on incident reports or behavioral logs. Explain in your report why you chose whatever force options you used, and point out what you did to help assure prompt and effective medical attention for the subject. And finally, you may need to remind the public that there can be no medical assistance until the subject is controlled. This concludes this talk on excited delirium.